Sir, we are live now.
Yes, Namrat, please go ahead.
Okay, it gives me immense pleasure to welcome our course director for today's session, who is Dr. Richa Poria, sir. Sir is the director and head of department at neurology at Sahyadri Hospital, Nagar Road, Pune. Sir has been part of the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has the credit of delivering more than 300 public lectures and workshops on stroke. Sir is a member of Indian Stroke Association and the organizing president of StrokeCon. Sir is the founder of the Pune Stroke Group and ex-president of the Society of Neurosciences Pune and Maharashtra Academy of Neurology. Sir has been part of multiple multinational stroke trials as the principal investigator. Sir has also been awarded as health icon by the Times of India Group. Sir, it is great pleasure to have you on board today. Thank you so much for joining us.
Thank you for the kind words. Yeah, will you introduce Dr. Sudhir Kumar?
Sure, sir. So our next, I would like to introduce Dr. Sudhir Kumar, sir, who is the moderator for today's session. Sir is the senior consultant neurologist at Apollo Hospital, Jubilee Hills, Hyderabad. Sir, being a DM neurology with 33 years of experience as a health professional, inclusive of over 22 years dedicated service as a consultant neurologist with reputed hospitals and healthcare foundations. Actively, Sir has contributed to the acute stroke program by writing several articles. He has participated in the successful effort made by Apollo Hospitals, Hyderabad to acquire the prestigious disease or condition specific accreditation by the Joint Commission International for the Stroke program existing in the hospital. Sir has the credit of over 120 publications in peer-reviewed journals, 9 books and chapters, and has 19 papers presented at various national conferences. Sir is also a member of a panel of peer reviewers of 12 journals, editorial board of 2 journals. Sir is involved in multiple clinical research and is the member of Ethics Committee of Apollo Hospitals, Hyderabad since June 2009. Sir is a member of prestigious national and international societies in neurology. I welcome you, sir.
Thank you very much.
Today, we have 2 eminent speakers which will be delivering talk on difficult cases encountered in clinical practice. So I would like to introduce our first speaker for today's session, Dr. Anup Gupta. Sir is consultant neurologist at DM Shah Hospital, Bhilai. Sir has the credit of over 10 publications in national and international journals, international books, chapters, and reviews. Sir is also has also been an executive member of INCON 2018. Sir has been the panelist of NAT Neurocon 2019 and an executive member of Chhattisgarh Association of Neuroscientists. Sir also has been the member of Indian Academy of Neurology, a member of American Academy of Neurology, and Movement Disorder Society of India. I welcome you, sir. Our next eminent speaker is Dr. Madan Mohan Gupta, sir. Sir is Center Chief and Chief Neuro Interventionalist at NHPH Jaipur. Sir has the credit of for over 9-year experience as an interventional neurologist and has been the gold medalist in medicine in MBBS and a university first ranker in neurology. He has performed over more than 2,000 diagnostic cerebral and spinal angiograms. Sir has performed more than 1,000 complex neurovascular interventions, and Sir has credit of more than 10 publications in national and international journals. Sir has also been part of multiple national and international oral paper presentations. We welcome you, sir. It is great to have you on board. So without further ado, I would like to hand over the session to Dr. Richa Poria, sir, for today's episode.
Thank you, Dr. Namra. It's a great pleasure to be here again, and we've had some wonderful programs. It's been going on for a year and a half now, and we've had some amazing cases, and there's so much to learn and so much to discuss. And I think Sudhir Kumar is in our group here for the first time, and he's a dear friend. And I welcome you, Sudhir. And
Thank you, sir.
I wish that you take part actively in the discussion. And of course, I welcome the speakers, Dr. Anup Gupta and Dr. Madan Mohan Gupta. And I'm sure that we will learn many things from you. And I'm sure you'll show us wonderful cases, and we'll discuss it as we go along. So, Dr. Namra, if we can start. Sudhir, would you like to say something before we start?
I think let us start. I think the cake is there. So let us.
Little loudly.
Yeah, no, I think we can start, sir. So I think, we'll start the cases and then we can always have the discussion as the cases are presented.
Yeah. So let's start. Who's going first? Dr. Namra, who's going first?
Dr. Anup Gupta, can we start with the case presentations from you?
Anup?
Yes. Very good evening, sir. Very good evening. Yes, I can start. Should I share my screen?
Yeah, your sound is not so clear.
Is it okay now, sir?
Yeah, little better, yes.
Yes. Should I start now?
Yep.
Yeah. So, okay. Very good evening. I'm Dr. Anup Gupta, practicing neurophysician, consultant neurophysician in Bhilai. So today I'll be this is a very simple case. So today I'll be speaking about one of my patient who I did thrombolysis some 3-4 months back, and patient is doing very well right now. So this was a 48-year-old male, non-diabetic, hypertensive, right-handed, graduate, CA by occupation. He presented to us with sudden left hemiparesis. Patient was disoriented, drowsy. The duration was less than 1 hour. Patient had history of TIA 1 year back, but patient was not taking any medication. So this is a very interesting case, and the reason being, patient lived some 120 kilometers away from our place, but for some reason he was near the hospital only, and while he was doing some shopping, so he developed sudden left hemiparesis, and the attendant was known to me, so he directly gave me a call. I asked the attendant to bring the patient as soon as possible to the hospital. They came in less than half an hour. As soon as he developed symptom, the attendant brought the patient to hospital. Within 15 minutes, all the process was done, and he had a past history of TIA, but was not taking any medication. So we admitted the patient. Blood pressure was normal, on higher side. Sugar was normal. Patient had right gaze deviation, left upper and lower limb weakness. Power was 1 to 2/5. So we asked for the imaging and routine test. So this was the initial CT, all normal, no nothing significant. So with investigations were normal. His NIHS score was 13. There was no contraindication for thrombolysis. So we gave thrombolysis at 0.25 mg per kg. Initially, there was no worsening. And after 1 hour, there was BP got shoot up to 200 by 110, but that we controlled and everything got fine. And after 2 to 3 hours, patient had slurring of speech, right gaze preference, and patient was dull, drowsy. But after 2 3 hours, patient had significant improvement in speech, left side weakness improved. There was only subtle weakness left. Gaze became normal. We got an CT angio done. That was normal. So there was no need for any vascular intervention. And then we got all the other investigations done. That was normal. So MRI was done after 24 hours. It showed patchy infarcts in right MCA territory, but patient improved very well. And in after 24 hours, patient was almost asymptomatic, very subtle weakness, no slurring, no gaze deviation, no other deficit. Patient was feeling fine. Blood pressure was normal. Everything was normal. MR angio was also normal. So after follow-up, after 3 months, patient recovered completely. Patient is very active right now. He's busy in his profession with no deficit, no problem at all. And this is the patient, no deficit right now, and patient is doing very, very fine. So he was very lucky that though he was staying 120 kilometers away from Bhilai, but luckily he was there in Bhilai when he got this event, and he came to hospital within 30 minutes, and patient recovered completely. Though lesions are there on MRI, but patient is fine, no deficit at all. So this was a simple case only, but since he came earlier, he recovered completely, and there is no deficit. And he being a chartered accountant, he is very busy now in his occupation, doing everything very nicely, and there is no deficit, nothing. So this is a simple case, but since he got very good recovery, that's why I presented this case.
I think it's a very interesting case. What is interesting is that he happened to be near to the hospital at
Yes,
the
sir.
right time. So one should get the stroke at the right place also. That's also important.
Sir,
And you have to come to the right place.
And come to the right place.
Yeah,
Yes.
yeah, that is also very important, because otherwise if they go to some nearby hospital, which is a gynec hospital, and they always tell you, I went to the closest hospital. It's not the question of closest hospital. You have to go to the right person. And the right now,
Patient attendant knew
now
Dr. Anup.
luckily the bystander knew Dr. Anup,
Yes.
so he could get to the right person. So good that you have spread your tentacles far and wide, Anup, and you should do that. We stroke neurologists now, we are sitting in air-conditioned rooms and just writing prescriptions. That's not the way to go. We have to go out into the community, and we have to educate as many. I mean, see, you cannot educate everyone in the world, but as many people as possible. Local politicians also, those fellows also want something from you. But okay, I think that is the important thing. So the patient came in time. So I'm very happy to listen to this, because your door to needle time was very good, and your stroke onset to needle time also must have been very good. Perhaps you could write that in your presentation. Door to needle time, how much it took. You said 15 minutes.
15-20 minutes only, because
Yeah. But
again,
when you do the presentation, you should write that
yes,
the
sir,
door
yes,
to
sir.
needle time was so much,
Yes,
and
sir.
stroke to needle time was so much.
Yes, sir.
That gives a good comprehensive idea. I mean, you have to give a picture of what happened. You have to give a pictorial picture of and what time did he come, Dr. Anup?
Sir, in the evening, sir, at 6:30.
So it came during working hours, no?
Yes, sir. Yes, sir.
Yeah. So now, we also have to get, as stroke neurologists, we have to get our system so that, even in non-working hours and on holidays and on Diwali Day and on Christmas Day and on New Year Day and whatever other days are, our door to needle time should be that much. So it is a challenge. It's not so easy. Sudhir, what do you think? It's not so easy to develop that team which is working 24/7, and but we should try to achieve that. It's one thing to do it in working hours and another thing to do it in non-working hours. But if we can do it at 2 o'clock at night and 3 o'clock at night, I think it's a great achievement. And then your numbers go up, and because your numbers go up, your experience goes up, and because your experience goes up, people have more confidence in you. And this is how the stroke message should go to the community. So this chap, Anup, should become a stroke ambassador for early treatment and early management. And the patient also should advertise. It's not advertising. I mean, this word advertising is used in a bad way, but it's so important for people to know where to come and how to come. So much time is wasted in doing a scan and an MRI and this and that, and he goes from place to place before the MRI is done. So, what you have done is excellent. 15 minutes, CT scan done, IV thrombolysis given. That's the way to go. You don't have to do so many investigations and waste time. So, many congratulations to you for that.
Thank you, sir.
I just want to ask, what do you think is the mechanism of stroke in this case?
Sir, patient being an hypertensive and patient has a history of TIA. So maybe and patient had in MRI large vessel occlusion. Patient had
but there was no large vessel occlusion.
Sorry. Patient had large vessel stroke. Patient had a stroke in MCA territory.
Yes,
So
distal MCA territory.
Yes, sir.
Maybe
Yes,
it was in M3.
Yes, sir. Yes,
Do
sir.
you have an angio before thrombolysis?
No, sir. No, sir. Before thrombolysis, actually, since it takes a lot of time, so I didn't go for angio before thrombolysis. I got it done after thrombolysis.
Yeah. So, if you have the facilities and if you have a good CT scanner, ideally you should do a CT angio.
Yes, sir.
I prefer, to give the thrombolytic agent and then to do the CT angio. But some people like to do the CT angio and perfusion, and then they like to give the thrombolytic agent. But I prefer to, just give it in the CT scan department, and then over the next 10-15 minutes, do the CT angio, because, you don't want to waste even those 1 minute and 2 minutes.
Yes,
And, it all adds up. Everyone says that, no, it took only 3 minutes. But this 3 minutes here, 3 minutes there, 3 minutes there, it adds up to 20 minutes. So, the stroke pathway which you have, I think is excellent. Patient comes into casualty, straight away goes for CT scan. You do the plain CT scan. You see that there is no hemorrhage and there's no contraindication, and just give it. And this is what has happened. This is what has happened, and this is the reason for the good result. I think door to needle time reduction is the most important factor or variable for good recovery. And many times, Sudhir, we have seen that, post thrombolysis also there is a DWI lesion, but still the patient is asymptomatic. So, many times I've seen, what you showed is not a very large DWI lesion, but many times we see big DWI lesion, but the patient looks fine.
Yes,
so sometimes really I wonder whether this DWI is overestimating the size of the infarct. Many times I feel that way. Dr. Agarwal, what do you feel, Dr. Madan Mohan? You're on mute.
Please.
Sir, I am fully agree with you. I can't say much more.
We can't hear you.
I am fully agree with you, sir, because these DWI are misguiding us that this is also my expense, sir.
Exactly. So, we do it, because it's in the protocol that 24 hours later you should do a scan before you start antiplatelet agents, and you should rule out hemorrhage and all that. It's okay to write that in the guidelines. But, if the patient is doing well and all, I don't think you should worry too much. Even if there are small little dots of hemorrhage, they are not significant. So, this DWI lesion should not scare you, because patient has done well. And, it was in the speech area. But even then, his repetition improved, his comprehension improved. It's a little posterior, so it's likely to be a receptive aphasia. And even that improved after a period of time. So mostly it was an M3 or M4 occlusion. And these really do very well with IVT. So, if it's more proximal, even the proximal ones do, not that they don't do. They do. Now, we don't know whether it was proximal or distal. NIHSS was 13. So it could have been in M2. It could have been. But, IV tenecteplase, I find that it works superbly well in these T2, M2, M3, even in M1. Almost 30-40% of them recanalize if the clot is small. And the biggest variable being early thrombolysis, early door to needle time, early stroke to needle time. And that is the biggest variable, according to me. And that really improves patient's outcome. And we are really very happy to see this happening. Sudhir?
No, I think you have summed up nicely, sir. So I think you have summed up very nicely. And Dr. Anup, he deserves all the praise for what he has done. And we also do the same thing. I think if a patient comes very early, we don't do CT angio. But if it is nearing 3 to 4 hours, then we complete the CT angio also, because sometimes they are the candidates who may require mechanical, but we have a little less time there. But I think here, if somebody comes in 30-40 minutes, then possibly each minute saved is, we can save millions of neurons. And that's what Dr. Anup also did.
Yeah, I think, Anup, as we find that the vessels are quite good, maybe you can do a little prolonged Holter, huh?
Yes,
Because sometimes these paroxysmal AF,
yes,
they can come like this. And, if you just do an ECG and echo, you may not be able to pick it up. So at least a 3 to 7 day Holter, especially if you find that the vessels are looking quite normal and pristine, it's worth doing it. Not that we find it very often, but, if you find it, the medicines change. So, it's worth doing that, It's
Okay,
worth
sir.
doing that.
We'll
And
do
you
that.
have to emphasize to him that he cannot stop medicines.
Yes, sir.
Stopping medicines is the biggest trigger and risk factor for recurrent stroke.
Yes, sir. Yes, sir.
So that is a big mistake that he made after a TIA. TIA is a warning attack. It appears minor, but it's not minor.
Yes, sir.
It appears minor to the patient. Kya re yaar, 2 minute tha, 3 minute tha. Nee, it appears minor, but it's a serious disease. Because, something else can happen. So you have to be aggressive in your counseling to the patient, that you have to take long-term, probably lifelong treatment. I think lifelong is the word you should use. When you say lifelong, patients get a little scared. Kare Baba, lifelong. How can I take lifelong? But at least you say that, as per the present knowledge you have to take, maybe tomorrow some new drug comes where you have to take only once in a lifetime, some injection and something. But as of today, though, you have to take. Tomorrow, we don't know. Now there are some cholesterol drugs which you have to take once a year. So you don't know now. So when you say lifelong, they get scared. So you should say that at present, you should take it continuously till you see me or till you this thing, but no stopping. And in the future, some new miracle drug comes, which you have to take once in a lifetime. Fine, that will be great if we can do that. And it may happen. It's not a figment of imagination or science fiction. It can happen. So maybe you can do a Holter. Just look for paroxysmal or intermittent AF, and then, because the treatment changes, So
Yes,
I think that little thing you should do. And sometimes, now, if the vessels look normal, then can we say it's cryptogenic stroke? So maybe do a TE.
Yes, sir.
It all depends, maybe we can do it. I mean, I would push a little hard and, get his cholesterol down to, LDL down to say 80, 90 or even less. And another thing, we only talk of drugs. We don't talk of lifestyle changes, to patients, what he should eat, how much physical activity he should do, how to preserve brain function. I think that is very important. We must talk to them about lifestyle changes and changing behavior, what you should eat. Now, he looks thin. This chap, his BMI appears normal, but still he's got a stroke. So, this Western concept that only high BMI people get stroke, aisa to nahi hai. Yes, many of our patients have normal BMI or low BMI. And then you should ask, if there is B12 deficiency or hyperhomocystinemia, maybe you can investigate for that. I think you should investigate for everyone. And in India, though, we find that, B12 and vitamin D are deficient in 90% of the population, including 80% of doctors. So I think on these points, I think you should push a little harder.
Yes, sir.
Maybe I'm talking too much. Sudhir, come on now I'm talking too much.
No, you're talking all nice things, sir. So you have how to work out for a patient where there are no obvious risk factors. I think you have summed up very nicely. And definitely they are important. And also you highlighted about the lifestyle. So, and lifestyle, we just say exercise and diet.
Yeah.
We should go one step ahead. And,
I think we should spend 5-10 minutes, talking on lifestyle for every patient.
Yes, and we should
5-10 minutes, I think we should spend. If you can spend, you get some assistant or, some psychologist or, somebody or a nutritionist or somebody to talk a little bit on lifestyle. I think that is part of the treatment. Treatment is not only aspirin and clopidogrel and statin and blood pressure and diabetes. It is lifestyle. I think we have to overemphasize this point. Overemphasize. Okay, so I think we've had a very, very good discussion on how to manage these patients and so many lessons to learn. You are saying it is a simple case, but in one case, there are so many issues which we have to think about and talk about. And, we need to give this message to so many thousands of people in the community. So it may appear very simple to us, but, it's very important what you have done. So congratulations once again.
Thank you, sir. Thank you.
Thank you. Sudhir, could you ask Dr. Madan Mohan?
Yeah, definitely. I think after this first case, now it's my pleasure to invite Dr. Madan Mohan to present his case. And then we can have the discussion after his case.
Oh, good evening all. Am I audible, sir?
Yes.
Little loudly, sir.
Okay, sir. And my slides are visible, sir?
Yes.
Yeah, slides we can see.
So, good evening all. This is a case of 56-year-old lady. She was operated for aortic valve replacement 2 years back, and she was on acetylene. I think before 3 months, she developed right side weakness, sudden onset, and she was unable to speak for 1.5 hours.
Little loudly, sir. Little loudly.
It was evening, sir. And around 5:30 p.m., everybody was leaving the hospital, and she ended up in the emergency. There was no history of diabetes, hypertension, hypothyroidism, or dyslipidemia. So at the time of presentation, we don't know what was the INR because she was taking the acetylene, but last INR was 1.7. As a protocol in the neurology team, stroke team, we did a CT scan first. And if we will found that there is any hyperdense MCA or anything, then we will do angiography in immediate settings. So this was the CT scan of this patient. It was showing a hyperdense middle cerebral artery on the left side with subtle hyperdensities over here, but there was no large hyperdensity or visible hyperdensities in the other areas of the aspects like the upper area as well as the ventricular areas. At a time, clinically, when we took up in the cath lab, she was altered. She was not following all commands. Few commands was she following.
जीभ दिखाइए अपनी, जीभ दिखाइए, आगे खोलिए, ये हाथ ऊपर उठाओ, ये वाला ऊपर उठाओ, ऊपर उठाओ.
Power was
ये पैर
zero
ऊपर
in the
उठाओ,
right side, upper limb and lower
ये
limb.
पैर ऊपर उठाओ, ये वाला उठाओ ऊपर.
Gaze division was there, aphasia was there. So NHS was 18. And this was the CT angio we did after the non-contrast CT scan in the CT scan department immediately to see the lesion. And we found that large vessel was from the common carotid artery and internal carotid artery is normal till the ophthalmic artery. And then after, this was the T occlusion, where supraclinoid ICA as well as the middle cerebral artery was completely occluded, and there was no good collaterals from the AC. So according to this NGO, we thought that this patient is a fast progressor, so we should take immediate decision. But problem was that she was on acetrom, INR was 1.7, and we don't know what is the INR at this time. So we explained the relatives in a very large way that this patient need either IV thrombolysis or mechanical thrombectomy or both if we will take the time. But there is a risk of bleed because she was on anticoagulation. So they took time to decide what has to done. So door to needle time when I took this patient in the cath lab was 2.5 hours. And she was taken for mechanical thrombectomy. By the history, we recognized that we identified that this patient had stroke due to the cardiac disease post-AVR. So maybe an unorganized clot was dislodged from the aortic valve and lined up in the middle cerebral artery. So it may be a fibrin-rich plaque or fibrin-rich thrombus that will be difficult to capture it out. So this was the DSA, first run. And this DSA was showing different picture from the CT angiography. On the CT angiography, it was the T occlusion, where the supraclinoid ICA bifurcation, as well as the middle cerebral artery was occluded. But when I took first run from the common carotid artery, the thrombus was seen in the distal MCA. Might be it may dislodge by my run or by the flow. I don't know what is the reason. This was the first angio, and this was the clot over here. This was a sign, and there was no good collaterals from the ACA as well. So this history, we took first pass through the Solumbra. We deployed our aspiration catheter into the distal middle cerebral artery. It is the aspiration catheter. Through that, we deployed a stent retriever so that we want to capture and pinched out the clot between the stent retriever and the aspiration catheter. If we will do that, then we may have first pass result in very high amount, high percentage. And if in this case, because we are thinking there is no good collaterals, there is this patient is on acetrom. So if first pass result will be good, this patient may had good recovery. This was the clot we retrieved, and on the histopathology, we found that this is a fibrin-rich clot. It was around 2 centimeter, 2.5 centimeter clot we retrieved from the ICA, MCA. So this was the TK3 flow. There was a good recanalization, all the distal branches, anterior posterior view, and we were happy. But when we did this post-procedure CT angiogram, CT scan, we found that this was the SAS, subarachnoid hemorrhage in the left sylvian fissure, as well as vessel cistern in this area and left side of cerebral hemisphere. So we identified that this may be a cause of the anticoagulation, and because of the mechanical thrombectomy, we did a trauma to the endothelium as well as the veins, and this may increase. So fortunately, we thought that we didn't thrombolize this patient, otherwise there may be major catastrophe. And in those cases, we would try to keep the blood pressure low down. We kept around 110 or 100. And we repeated a CT scan after 3 hours to see is there any increase in size, and as well as we clearly watching and monitoring the pupil size as well as any clinical deterioration with the heart rate as well as the blood pressure. So it was not there. And after 3 hours, CT was also showing same amount of blood, which was resolving little bit and not increasing. And in this CT scan, we identified that there was a small amount of the hypodensity was predicted on the left side superior division. So we thought that this patient will develop this area of infarct in this area. This was the CT scan after the 24-hour. You can see there's a well-formed infarct was in the superior division of left middle cerebral artery with patchy areas of the reperfusion because of the mechanical thrombectomy. And this was the Sylvian Fisher SAH as well as the basal cistern SAH because of the trauma. We repeated this CT scan as well as after 3 days to see any mass effect. It was not there. This was immediate post-procedure patient after 24-hour, or this patient developed improved in the upper limb power and consciousness, and the comprehension was improved, but aphasia was still there. After 3 days, when she was discharged from the hospital, she could say some name, but she had naming aphasia, and comprehension and upper limb and lower limb power improved till 4.5 hours, 4 plus 5. This was the discharge picture. Clinically, she was able to walk independently and she can follow command. But she still have aphasia, which is on the improving side. So this patient taught us that we should do mechanical thrombectomy if required immediately, and the between thrombolysis and the thrombectomy, what should be taken simultaneously, what options were discussed with the relatives, and with the pros and cons, we choose mechanical thrombectomy in this case, particularly because of large vessel occlusion. Second thing, acetrom. Third thing, fast progressor. Thank you very much.
I think this was again a very, very good work done by Dr. Madan Mohan, and definitely you deserve a lot of praise for this. And I think here it was not a straightforward case. The number one thing was patient was taking acetrom that you highlighted, and not only that, even INR was 1.7, which is on the higher side. And in such a patient, if we go for IV thrombolysis, definitely the risk of bleed will be high. And as you pointed out, without doing thrombolysis, still patient had SH. So of course, high INR also contributed. It may be due to procedure also, but high INR is also contributory factor. So in hindsight, all the decisions that you took, everything is you and your team took the correct decision. And maybe there was a little bit of delay, but I think despite that, patient had a very good outcome because possibly not much time was lost. So I think a lot of good things happened. Dr. Ishapuria, sir, your comments.
Yeah, that INR was done when?
So this INR was 2 days back, and after the thrombectomy, we come to know it was 1.73. So we were taking 1.7 is in our mind because this was we know, because we don't want to waste our time to get to know the INR, because we are losing the neurons at that time, sir.
Yeah, no, I'm just asking just to know, you know, but I don't know. Many of these places, no, they have this point of care INR, you know, that machine. So you know you can do the INR in the casualty, and many of the cardiac surgeons, they have this point of care. So it's not fully accurate, but it gives you a reasonable idea. So, you know, to do INR, sending it to the lab takes easily half an hour to 45 minutes, if you're lucky.
Yes.
It may take 1 hour also. But minimum time that it takes is 30 minutes, let's say. So, yes, we don't want to waste time. But, you know, if that place is doing a lot of cardiac surgery and valve surgery, I think we should have those point of care INR machines, just like a glucometer. So, you know, that saves time. But even then, because it is 1.7, it's totally borderline. So I would also not have given IVT. I would have gone straight for mechanical thrombectomy. And what you have done is absolutely excellent. Probably there was clot migration. So what you saw on the CT scan, that distal ICA was occluded, and then when you took her for DSA, the clot had gone to distal M1. So probably it was clot migration. So though the clot was huge, the clot was at least on CT scan it looked 2 centimeters.
Yeah,
on CT scan, and even when you removed it, it was 2 centimeters. So it was not likely to dissolve with IVT.
Okay.
If it is small, if it is say less than 8 millimeter or 5 millimeter, then it can dissolve with IVT. But 2 centimeter, you have to do mechanical thrombectomy. So what decision you took was absolutely correct. Now, another thing is that when you do the scan immediately after MT, many times you cannot distinguish whether it is blood or whether it is dye.
Yes, sir.
So initially, when you showed immediately scan, I was thinking, why can this not be the dye? And actually, the dye goes away in 24 hours. So if it is a dye, so when you did it after 24 hours and after 3 days, there was still hyper intensity. So therefore, it was blood. So probably it was. I wouldn't say you ruptured the vessel. I don't think you ruptured the vessel. I think it was a hemorrhagic conversion of the infarct. At least that is what I think. Did you puncture the vessel, you thought?
No.
No,
Sir,
no.
Studies
So
are saying
if you had punctured the vessel, it would have been catastrophic bleeding.
yes, sir.
This type of bleeding, I don't think you should worry, because this is probably reperfusion hemorrhage. It is small. We would classify it as hemorrhagic infarct type 2. It is not parenchymal hemorrhage type 2. Parenchymal hemorrhage type 2, the NIHS has to go down by 4 points, which never happened. And there should be mass effect, which never happened. There could be intraventricular spread of the hematoma, which again never happened. So I would classify this as hemorrhagic infarct type 1 to 2. Which is this classification? Heidelberg classification. Heidelberg classification of reperfusion hemorrhages.
Yeah.
So hemorrhagic infarct type 2, I mean, it worries us, but it's not a major worry. So probably she had infarcted in the perisylvian region, and that is why she had aphasia, and that is why her limb power improved. And because it was perisylvian, her repetition was impaired and her comprehension was impaired. But I expect that over a period of time, maybe 2-3 months,
Yes.
we are just seeing in 3 days. 3 days, her NIHS, you said was how much? 15?
Yeah, it was 18 first.
18. From 18, it has come down to 2 and 3 and 4.
Yes.
So it's amazing. It's amazing what mechanical thrombectomy can do in the right patient, in the right scenario. It's amazing what mechanical thrombectomy can do. And you have really given her a second life. And many, many congratulations to you. And I'm sure over a period of a few months or few weeks, her aphasia, it may not improve completely. There may be little comprehension problem, and maybe she may not be able to speak all languages, and maybe the mother tongue will come back first, and the other languages may not be so fluent. But it's okay, I mean, she's had a major stroke. She could have died otherwise.
Yes, sir.
Definitely, she could have died with this huge MCA infarct, and there was no collateral circulation. And definitely, she was a fast progressor. So we must congratulate you for the excellent work done. And I hope the family is also very happy with you and should congratulate you.
Our team is led by Dr. Suresh Gupta, sir.
Yeah.
Internal hospital.
So congratulate him also. He's my good friend.
Yeah, I know, sir. So that I heard about you, sir, a lot. He was telling me many times.
Yeah.
Patient is referred
So I think And finally, it's the team,
No,
Dr.
it's a teamwork.
It's the team. Yeah, you can't do this on your own. Yeah.
No, sir, it's not
Nobody can do this high quality stroke work on their own. You have to make a team. You have to have the interventionalists available. He should also come in time. Anesthetist should come in time. Cath lab people should come in time. Uh, you know, for doing mechanical thrombectomy, you require 23 people. 23 people team you have to make. I don't know how many. You need anesthetists, you need ward boy, you need person, radiologist, you need interventionist, you need ICU team, you need emergency department people. So you need 23 people to do mechanical thrombectomy properly.
Sir.
So it's a high intensity job. It is a lot of adrenaline and steroid hormone also gets secreted in your body. So I'm sure. And when you see a scan with bleeding in the brain, again, your heart skips a beat.
You are right, sir.
And you get some mild arrhythmia. So, but it's fun, and I'm really very happy to see the wonderful response that you have got. So, many congratulations to you and your team, and it's wonderful that what you have done. So, in this case, clot migration is an issue. Reperfusion injury, not an issue, but these are the things which happened. I mean, it all turned out well. So that's pretty good. Sudhir?
Yeah, I think most of the things you have covered, except I had one patient with INR of 1.7, and that was in 2003. And that time we didn't have too much of interventions. And it was a doctor, and his wife also was a doctor. So with a lot of discussion, debate, everything, finally the family and the doctor himself, he was not aphasic. He had normal cognition. So he and his wife, both of them gave consent to thrombolyze. And as expected, he had a massive hemorrhage.
Oh
And
my
then
God.
surgery was done, and finally he required a lot of rehab. And it took a lot of time. It took him 6 months time to recover because of bleed. So this INR 1.7, after that I have never.
1.7 is borderline, huh?
Yes, but we can't
1.7 is
predict
borderline.
who will not have a bleed. We can't predict.
I mean, that you cannot say. Yeah.
Yes,
That
but in the best interest, we all decided that day. But but he required surgery. But it was a long course. Finally, he came out. But still,
no, once hemorrhage occurs, I mean, we are in trouble. But I don't think that should deter us.
Definitely.
Actually, the recommendation is equal to or greater than 1.7. You should not give IVT. Greater than or equal to.
Yes.
So the Madan's case was, I think, 1.73. You said, no?
1.73. Yes, sir.
Yeah, 1.73.
Came out.
So
Yeah.
it was above 1.7.
Yes.
So, Bapre, if something happened, then khalas. So better not to do it. And this is one indication I would think of doing direct MT. Otherwise, usually I prefer, I don't know, you interventionists may not prefer, but I prefer to give IVT before MT because many times it does open. But here the clot characteristics were not favorable for IVT. It was too long. It was a fibrin clot. It was mixed, from what you showed. It was white and red, both mixed. And the length was too much. Length was 2 centimeters almost. So IVT would not have worked. So this is an ideal case to do MT. And I think you've done very well in that. So I think that's all that I need to say. Sudhir, you want to say something?
No, I think you have summed up nicely, sir.
Yeah, we've covered everything.
Yes.
Any questions from the audience, if there is any? Dr. Namra?
No questions as of yet, sir.
For both the cases?
Right, sir. In the chat summary and in the Zoom meeting, there are no questions as such, which have come up till now.
Okay. then shall we stop the meeting? Would you like to sum up, Dr. Namra?
Sure. Thank you so much, sir, for providing time for the meeting. And we are extremely grateful to you and thankful for all the wonderful clinical insights that you have provided to us. I would definitely like to thank Dr. Sudhir, sir, for being a part. And the No Traumas workshop has been going on since the last 76 episodes. And we definitely benefited from your insights through the case presentations which you gave us. And I would also like to thank our eminent speakers for today for the excellent case presentations, and we are extremely grateful for the same. We have 376 attendees today, sir.
How many?
376.
376.
Yes, sir.
Oh, that's a good number.
Yes.
Sudhir, all because of you.
No, sir. I think because
a handsome fellow from Hyderabad is coming, so 376 people.
No, but we had good cases. I think they got their
Very good
recorded
cases,
work.
and I'm sure all the 376 have enjoyed it a lot. And thank you, Anup, and thank you, Dr. Madan Mohan. Excellent cases, and I think a lot of good messages have been conveyed to all the 376 people. Dr. Ankush?
Yes, sir. So thank you so much. Your insights always have helped as a course director for this meeting across last 1.5 years. And thank you so much for giving insights to these wonderful cases. I would especially like to thank Dr. Anup and Dr. Madan for their beautiful cases. And Dr. Sudhir, sir, thank you so much for being here. I wanted to personally meet you. I am great. Dr. Just to give you one insight, Dr. Sudhir has a lot of fan following on Twitter. He has more than 64,000 Twitter followers.
That's what I'm saying. Because of him.
Thank you.
Because of him, we got such a good audience.
Absolutely, sir.
Today only I was remembering you, Sudhir, in the afternoon, because there was a case of dissection, and that woman, she was washing her hair in that salon with her hair at the back and her head on that pillow.
Stroke syndrome. Yeah.
So we remembered you, that you had published this case, and you have become world famous for that case.
Published on Twitter, sir, not in any medical journal.
I know, even then, man. Okay, so, and Dr. Namra also anchored the show very well. This is her first time I'm seeing her.
Right, sir.
Huh?
Yes, sir. This is the first time I'm joining.
And you anchored it very well and confidently. So many thanks to you and congratulations.
Thank you so much, sir.
Thank you. Chalo, bye.
Thank you. Have a great
night.
evening.
Thank you.
Thank you, everyone. Bye-bye.
Thank you, sir. Bye.